Hey, how you doing? My name is Ken Kinter. I'm an assistant professor at Rutgers University, and this presentation is an introduction to something called illness management and recovery, or IMR. And you can see our website here at the bottom. As always, if you like what you're hearing, go tell someone. We appreciate comments. We love it if you could subscribe. And if there's anything you think we should cover that we have not, please do. Okay, this presentation is sponsored by the New Jersey Department of Health and the Department of Human Services, as well as Rutgers Institute for Inpatient Psychiatric Rehabilitation. Our purpose is to improve the quality of care and also working conditions at New Jersey state psychiatric hospitals. We are grateful for the support, financial and otherwise, that makes this work possible. So, as I mentioned, this is an introduction to something called illness management and recovery, which is a manualized group. Which, if you work with people with severe and persistent mental illness, it's a great group in one package. We're going to talk about the different components of illness management and recovery, and also the things that you also need along with the actual materials to make an IMR group or an IMR implementation work. So illness management and recovery is um, it's a structured step-by-step program that helps people set goals, learn information about their illness, and also make progress toward their own personal recovery. It's been out for quite some time. IMR has several goals, which is inspiring hope, learning about mental illness and the treatment for those illnesses, reducing relapses, and also the general idea is the more you know about your illness, the more power that you have and can possibly improve your situation. So, a couple of the things that are essential ingredients of illness management and recovery is hope, the idea of self determination, that you have something to say over your life, that mental illness doesn't change that, uh, orienting to the person, treating the person as a person and not necessarily as a patient or client, and the attitude of partnership and respect. Illness management and recovery, what makes it work is it has a very good structure. It covers an awful lot of material. It has a very easy to use format, especially with people that have maybe some challenges in learning or are very symptomatic. It has a very strong recovery orientation, and there's also a very strong evidence base for it. And those are some of the things that separate it, make it unique. So if you run groups, it pretty much is everything you need in one place, one tight little package. So IMR has a couple different components. Psychoeducation, it helps people learn about their illness. It helps address medication adherence by what's called behavioral tailoring. It's about how do you remember to take medication, as well as covering the why of people taking medication. Some people don't take medication because they don't want to, and some are just not good at remembering to take medication. I'm kind of one of those myself. Relapse prevention, coping skills, social skills, if these are things that you do where you work or want to do, then this can help you get there. So, how IMR is set up, it takes about 6 months if you do meetings twice a week. It can take longer, like 9 months or a year, depending on uh, your participants. It's best done in a smaller size group, about 6 to 8 people. And basically, what happens is the people in the group set goals at the beginning, and then they practice skills both in the group and outside. Uh, learning by talking about it in the group, but also by practicing it. There are 11 modules, and the practitioners use skill sets of their own to bring the material across. The second half of this video really talks about what you need in addition to IMR to be able to make IMR work. So we'll get more into that. Each IMR session follows this format. We'll say the first third of the session is informal socializing, reviewing the previous session, and reviewing practice assignments, things that people are doing outside of group to work on their goals, as well as following up on goals. And that's usually the first third. The middle third is setting the agenda for the current session and teaching new material. And then the last third of group is developing the practice assignment and summarizing the session. Basically, what did you learn today and how can you take that into the world from here? The educational handouts, there's two sets of handouts. There's a set of handouts for the participant and also for the facilitator. The ones for the participant are broken into clear topic areas, 4 to 7 topics for each module. As we mentioned, there are 11 modules. There are prompts to help apply the information that's learned in the material. There are practice assignments in each topic, and it takes on the material in small pieces and summarizes it. So there's some repetition built in to help with learning. So what you have here, this is an example of a page in Module 5, which is the medication module. And it has the major topic, which is learning about the role of medications in managing symptoms. And then you can see in bold underneath how it's broken down, why medication is recommended as part of treatment, and personal beliefs about medication. So in the top right corner of the page, you can see that you're in Module 5, and this is topic 1. And then there are these subtopics underneath that. And not only is there a section where there's reading, but there's parts where there's questions. The idea is that the participants all have their own handouts and then they fill them in and answer these questions for themselves, thus personalizing the material for themselves. It also has possibilities for role plays because it's much better to practice something and actually try it than just to talk about it. We'll talk more about that later. So let's cover the 11 modules. Now, a word about the batting order of these modules. Um, they're you're kind of open to what order you want to do the IMR modules in, with one exception. They really strongly recommend that you do module 1 first. Module 1, as you can see right here, it's called Recovery Strategies. It talks about a person's own personal definition of recovery and helps them identify areas in their life that they might want to improve, setting a goal, and then breaking that goal down into smaller steps so that they can start making progress toward it. Recovery Strategies is really the engine that pulls the train. So it's really important to get an idea of what a person's goal is and what they want, and then that will help move them forward. And then the modules that come after, you have a little bit of freedom about how you can actually do those. I've seen people turn it over to the group after module 1 and let the group decide what they want to do next. Some people go straight through the book front to back, and other people have the facilitators have kind of prioritized, and I'll give some examples of that as we go. So module 2, practical facts about mental illness. This one is pretty unique in that it has a lot of information about specific mental illnesses, such as schizophrenia, schizoaffective disorder, major depression, bipolar disorder. We have also at Rutgers added some similar modules that aren't IMR but are IMR style that addresses PTSD and also personality disorders. So you can reach out to us if you want to um, learn about those or possibly access those. I'll show you the website at the end. So in here, it talks about what the symptoms of the illness are in plain language so people can understand it, what can be done about the illness, and also an extensive discussion about the stigma about mental illnesses, which is it's a great topic. That makes for really great groups. Module 3 is the stress vulnerability model, which addresses the question that people have, where did mental illness come from? And the stress vulnerability model is that it's biological vulnerability plus environmental stress equals mental illness. And this also deals with the stigma of mental illness because a lot of people feel that they've done something wrong. And this kind of lays out that, hey, wait a minute, part of this is biological, and then part of this can be a result of stress. It's not about blame. So it talks about the cause of mental illness, what can contribute to symptoms, and what can improve symptoms and reduce relapses, and talking about different treatment options that are available. Module 4 is building social support. It's about looking at the relationships you have and then how to develop new ones to develop your support network. Number 5 is about medication. Now, you don't have to be a medical person to do this module. You can just review the information that's in it. Talks about the role of medication in managing symptoms, talks about side effects in a very straightforward way. A lot of times, people don't talk about side effects because they're afraid people are ambivalent enough about taking medication, and that's kind of a mistake because then people aren't expecting side effects, and when they happen, they view it as the medication not working instead of something that might be temporary or something that can be, balancing that with the therapeutic effect of the medication, making informed medication decisions and being able to get the best results from it. A lot of times people have difficulty talking with their prescriber about their medications, talks about that as well. Module 6 is about drug or alcohol use, why people use, what makes it a problem, the pros and cons of sobriety, and then making a personal sobriety plan, which introduces changes in behavior, changes in thinking. So there's a couple places in module 1, there's a goal plan that a person fills out and does. Here you have a personal sobriety plan that you fill out. And here in module 7, reducing relapses, and this is a module that I like to move up sooner in the rotation. In the inpatient facilities where I work, we don't have people for that long, so they might not be in the hospital long enough to get to 7, so we move 7 up. I like putting it right after 1, but that's a judgment call for you. Reducing relapses. The ultimate goal of this module is to create a relapse prevention plan, and that's done by identifying triggers, early warning signs of relapse, and then putting this plan together and into practice. I'm a big fan of this one, hopefully to prevent readmissions. Module number 8, coping with stress, talking about what stress is, how it feels to people, how it impacts people's symptoms, and then also a number of relaxation techniques, ways of, if you've ever run a stress management group, this is your material right here. And then there's also a plan that you make for being able to deal with stress, which everyone has to deal with. That's not even a mental illness thing. Coping with persistent symptoms is module 9. So dealing with the symptoms that don't go away due to medication or that are always going to be there to some degree, whether it's depression, anxiety, psychotic symptoms, low energy, problems sleeping. So just being able to deal with all that stuff. So, and the idea is to empower people that there are things that they can do about these symptoms outside of medication. Obviously the goal is that hopefully the person can function on less medication. Getting your needs met in the mental health system is module 10, and it talks about all the different services are available. Again, it promotes empowerment by having the client look at the services that are available and say, I want that, instead of just being assigned to a service, and maybe educating them about the services that are out there or that they're already getting. Module 11, healthy lifestyles. This is a wellness-oriented module. It addresses diet, exercise, hygiene, and sleep. One thing that I really like about the hygiene element is that it plays up the role that hygiene plays in maybe having in dating or having a girlfriend or boyfriend, something like that, to try to motivate someone to improve their hygiene. Maybe people don't want to tend to their hygiene, but they might want a relationship, and this is a means to an end there. Now, as we mentioned, not just enough to have the IMR materials, which at the end of the presentation will tell you how you can get them. You need other things, and this is a list of those other things that we're going to review in this half of the presentation. So IMR is an evidence-based practice, which means there are a number of studies that show that IMR is effective at helping people feel better and specifically get out and stay out of the hospital. My colleagues did a study that showed that the more IMR people had, the longer they were able to stay out of the hospital. And these research studies have been done in numerous countries. IMR has been translated into numerous languages. So the good news is if you do IMR properly, you get these therapeutic effects. The bad news is it's an evidence-based practice, so you have to do it to some level of fidelity, which we'll talk about now. So when implementing IMR, there's a couple things that you need. One is you want to have a certain level of saturation. That means that everyone who can benefit from IMR should have access to it. That means you have to train people, there's some allocation of resources. Who's going to do it? Where is it going to happen? How often is it going to happen? Who are the people that might benefit from it? Because again, IMR is a tough group compared to some other groups. If someone has trouble with much easier groups, they may struggle in IMR. But my belief is to give people a chance, see how they do. Some people rise to the occasion. And then sometimes the reason people aren't doing well in group because they don't feel challenged. So saturation, does everyone who can benefit from it have access? Fidelity, programmatic fidelity and clinical fidelity. Programmatic fidelity is that you're doing the group people are trained, that the group is happening with regularity. It starts on time, it finishes on time. People have handouts, all those sorts of things. And then the clinical aspects are the clinicians using the skills? Are they using motivational skills, educational skills, cognitive behavioral skills, all those elements? And then the last is sustainability, how this lasts over time. As hard as it is to get an implementation off the ground, it might be even harder to keep it going. Because what ends up happening is either the next thing comes along and bumps it out because we're going to put all our energy into that, or things have a funny way of drifting back to the way they were before. If IMR is new or different to your organizational culture, there might be some overt pushback and there also might be some subtle pushback. So it's making sure people can get it, making sure it is what that it's being run the way it's supposed to with fidelity, and that it gets carried out over time. One of the keys to making that happen is clinical supervision, that the people who do IMR meet on a regular basis to talk about how it's going, to discuss problems, ways of improving the implementation, getting the support that they need. An IMR group can be a comparatively heavy lift to other groups, but that's what you get to get the benefits. And a certain amount of support and networking is necessary. I notice if you give the facilitators time to meet together, they'll solve their own problems, but it's a matter of dedicating the time to it. As I mentioned, goals are absolutely critical in IMR, and this is right out of Module 1. In fact, I actually encourage people when I do these trainings to do this exercise themselves. If you want to pause it and do it right now, go right ahead. If you see this part where it says satisfaction with areas of my life, and it mentions all these different areas of life and how satisfied you are with them. And if you want to make a change in them, let's start with the areas of your life where you're not satisfied, which I'm sure we all have areas that we are and aren't satisfied with our own life. And that way you make this personally meaningful to the person. They're going to be willing to work for something that they want. They're not going to work for something because I say so. So goals are a big challenge, especially when you're working with people with severe and persistent mental illness. And our way of handling those goals traditionally has not been so great. Very often, I'm sure you've had clients before who've said things like, "Oh, I want to be the president." And usually what they get told is, "Well, that's not really a realistic goal. Can you pick a more realistic goal?" It's kind of shooting that person down. Uh, in the IMR way, what we would usually do is two ways to approach that. One is to let's indicate all the steps that it takes to become president and see if that person is willing to do that. They don't have to be willing to become president that minute. They have to be willing to take that next step, whether that's a GED or getting out of the hospital or whatever that is. You can direct the energy toward that next step. We're not having an election just yet, that they're in. But that way you haven't shot them down. They're moving in the direction of that goal, and the goal may change as they get moving. The other way is, and I'll take the example of a client that we had at one of the New Jersey state hospitals. He said he wanted to be a Marine. Now, this gentleman had spent most of his life in and out of state psychiatric hospitals. He was quite advanced in age and not in such great physical health. So, probably not a candidate for Paris Island. But when asked why he wanted to be a Marine, he said, people feel safe around Marines, people feel respect toward Marines. So then we said, okay, so is there a way people can feel safe about around you and respect you without necessarily having to go through basic training? So he didn't really want the Marine part of it. He wanted something, the Marine was like a means to an end. So again, we stayed faithful to what his goal was, but we're able to move in, a better direction about that. So again, we get this goal and then we break it down into its small component steps. I think Dr. Martin Luther King Jr. once said, it's not the whole staircase, it's just the first step. So we just focus on that next step. Following up on goals in each group is important. What did you do this week? What did you do in the last couple of days to accomplish this goal? And then dealing with the barriers and obstacles that come up. Of course, the goal hasn't happened yet. That means there's a barrier or something that stood in the way. How do we deal with that? Are there ways we can involve significant others, that person's social supports, into helping them get where they want to be? Being positive about it. There's a really big difference between a group facilitator who says, look, I think you can make it. If you put your energy into this, you'll be successful, as opposed to, well, that's an unrealistic goal. And of course, the big picture is that person getting better and moving to whatever the next level is from where they are now. So again, I work in the hospital project, so we are a little jaded on the term homework. The hospital is no one's home. So we call it practice assignments. Yes, it makes it longer, but so you practice a skill in group and then you practice it out of group. In our case, might be in the hospital on a unit somewhere. But the idea is getting people to experiment both in and outside. And I've noticed the people that put in the time outside of group tend to be the ones that get the best results. So in each group session, we ask, both these assignments are assigned, and then in the next group, in the beginning, they're reviewed and followed up on. And when that happens, we do something called praise, problem solve praise. I've also heard it called praise, polish praise, or the sandwich. And that is that when you're giving somebody feedback, you start with something positive, you end with something positive, and then you have something that's constructive in the middle somewhere, maximizing the impact that it has so that someone actually hears it. You've praised them so they haven't just gotten criticism, but at the same time, you've given them some constructive feedback that they can use. Very helpful in supervision and also helpful in the IMR groups. So, skills that the practitioners will need to be able to run IMR effectively. And what do you know? We have videos about these things too. You might want to check that out. Motivational skills, educational skills, and cognitive behavioral skills. Again, not somebody who's licensed in motivational interviewing or cognitive behavioral therapy, but is just familiar with these techniques. For example, being able to help motivate, help draw into the motivation that people already, excuse me, already have. Many times people say, oh, our clients have no motivation. They have plenty of motivation. They just don't have motivation toward the things that we would like them to be motivated toward. We have to tap into the motivation they have. Motivation to work, motivation to be home, motivation to be discharged from the hospital, motivation to go back to school, whatever it is that they want. How do we partner what happens in IMR to their own motivation? If they do not, if it doesn't involve their goals, why bother? If they don't have anything at stake in it, again, they're not just going to do it because we told them to. So some of the techniques to motivational techniques are, and you can see them here, connecting the IMR material to the goals, talking about barriers, exploring the pros and cons of change. Again, if you're familiar with motivational interviewing, which again, we have a video about, that's very helpful. Reframing experiences in a positive light, sharing recovery stories, and just conveying that hope and confidence in the group setting. If you're familiar with stages of change, which I'm a big fan of, that's something also that we explore in IMR. Where is someone at on this continuum of change? And again, if you're not familiar with stages of change, we've got a video about that. I find that extremely helpful. Motivational interviewing also involves something called OARS, um, open-ended questions, affirmations, reflective listening, and summarizing. These are communication techniques so that you can help somebody move forward through the change process. So as far as educational techniques, we are huge advocates of what we call the tell, show, do method. People learn different ways. Some people, I mean, think about, let's take the example of changing a tire. Now, some people, if you tell them what to do, they'll do it. Some people need to actually see it done. Oh, let's watch the video. I'll watch a YouTube video about it, and you learn how to do it. And then other people need to actually do it themselves. They haven't really learned it until they've done it themselves. Because how many times have you gotten instructions about something, and then when you go to do it, there's something different about it, and now that's when the help is needed. So tell, show, do. You see it, you hear it, you actually get a chance to do it with assistance and guidance and feedback right there. And that's the discussion that happens, throughout. There are also many other educational strategies to help bring the material across, whether it's reviewing the session, use of repetition, the use of the handouts, Chunking, breaking the material down one sentence at a time, one paragraph at a time, making sure people got it. It isn't the speed that you go through the material, it's the thoroughness and it's that people get it. Role plays, exercises, demonstrations, huge points. And then, of course, at the end of group, summarizing each group and processing it. The one that I seem to observe that most facilitators have the hardest time with is cognitive behavioral strategies, the whole overlap between what we think, what we feel, and what we do. Also, got a video about that one. You've heard this before. But just in terms of a quick example, people have automatic thoughts, and some of these automatic thoughts are positive, some of them are negative. If you have a negative thought like I can't make friends, that can result in feeling lonely, sad, and then that can lead to the behavior of staying inside and isolating. And the whole idea of CBT is that you can intervene in where these little arrows are. You can get in between those and make changes. So if someone says, well, I can make friends, well, that's going to change the way that they feel, and that's going to change how they act. And we have a certain amount of control over that. The problem is that these thoughts are largely automatic. They've just been burned in through repetition, but they can be unburned in, or new ones can be put in over top of it, or they can be modified. So there are very many cognitive behavioral techniques. And again, this is not cognitive behavioral therapy. This is just the techniques. And these are some of them. Positive reinforcement, shaping a behavior. A person doesn't get from right where they are to where they want to be. There are steps along the way, and they can just take a step each time. Modeling, which is something we actively contribute to. You know, we are role models for how to act in a group, as are their fellow participants. Practice, practice, practice. Our department head has a saying, practice makes better. We're not about practice makes perfect. There is no perfect. In fact, perfect is often the enemy of good. And then cognitive restructuring. Very often, I notice our clients react one way to things. They only attribute one possible cause, so they react as if that's the only possibility. Cognitive restructuring, I like to refer to as establishing reasonable doubt, which is, oh, there's another way this could have gone. So that means there's another course of action. You're not pinned into one view of something or one response to it. So I like this. The point of recovery isn't to live without life's ups and downs. It's learning how to live with the ups and downs. And I make the analogy, we live not too far from the shore. So it's not getting knocked over by the waves. It's kind of riding along with them. You get out there and you're in that spot where you just kind of ride the waves instead of having them break on you. So repeatedly during this presentation, I talked about our website. Our page might look a little different, but our address is the same, the sites.rutgers.edu slash SHP, SHPRI. There are a lot of videos and a lot of resources and materials on this page, many of which are free. I encourage you to check it out. Um, if that may be how you found this video, or you may have found it through YouTube, but I encourage you to take a look through there. There are things about all sorts of topics about mental illness, addictions, trauma, psychiatric hospitals, and things that can help you with your IMR implementation as well. These are the resources, and the bold resources are the ones where you can actually locate illness management recovery materials. At the bottom here on the SAMHSA site, there's an older version of IMR that you can reach and get the free materials if you want those. And then this, the one that's bold-faced up a little higher, Gingrich and Musser, that is a newer version of it, which you pay for. I don't know the exact price of it, but it's a binder. That you can buy, and it's through Hazelden. And these are more of the materials that we discussed as part of this presentation today. So once again, I thank you for your time. I hope you enjoyed the video. I hope you do consider using illness management and recovery in your program where you work. If you have any questions about it, don't hesitate to reach out to us. And just in terms of an update, we are, at this time of this recording, we are working on versions of illness management and recovery for an inpatient population and for a forensic population. So either access us through the Rutgers website, or you can put my name, Ken Kinter, into YouTube and you can reach me through that, or comment on this video and we'll reach out. Anyway, take care. Thanks for watching, and talk to you again soon. Bye-bye.